So we're going to talk about our difficulty breathing patients right now. And we're going to divide those many different types of patients and many different complaints into basically two categories. Those that have issues with oxygenation and those that have issues with ventilation. Here's an overall view of the respiratory system, including the upper airways and the lower airways. Some sources like to discuss difficulty breathing patients in terms of some sort of division between the upper airway problems and lower airway problems. We think we should approach it from the ventilation and oxygenation standpoint. So patients with ventilation issues may either have airway obstruction, whether it's in the upper airway or down in the bronchioles, or they may simply just not be moving enough air. If you have tongue, epiglottis, other issues in the upper airway, again defined as above the larynx, if you have obstructions up there, then the rest of it doesn't really matter. So let's assume we can get those fixed. Then there could still be some obstruction further down in the bronchioles. Maybe the bronchioles are constricted. Maybe they're plugged with mucus. Maybe there's inflammation. Maybe there's all three. So as we look at patients with ventilation issues, we want to look at the obstruction issues from upper airway down to lower airway, but we can't forget the very basic concept that maybe there's just not enough air moving in and out. Maybe the breathing rate is too slow. Maybe the person has some sort of CNS injury or an overdose, or they're hypoglycemic, or for whatever reason they're breathing 4 or 5 times a minute. They're having a ventilation issue because they're breathing too slow. Maybe they're breathing too shallow. Maybe it's both. So it could be tidal volume, it could be breathing rate. Those two add up to minute volume. So we need to make sure there's enough air that can move in and out because of clear airways and there's no obstructions, and that there is enough air moving in and out. Quick look at the upper airway. Again, we're talking anything from the larynx and above. Nasal passages serve to warm, to humidify, and to filter air for us. And then the mouth and tongue and esophagus, of course, has the dual role in nutrition as well as in airway and ventilation. Multiple opportunities here for airway obstruction. So one of the first things in dealing with patients who have a ventilation problem is to make sure that we have a patent upper airway so we can at least move air in and move air back out. Quick look at lower airway. Again, trachea comes down to the carina, then you have your right main stem, your left main stem, and those bronchi continue to divide into smaller and smaller and smaller and smaller airways, and it's the bronchioles that will really cause us some problems with ventilation when they become constricted. They become narrowed due to muscular constriction of the bronchial walls. They become narrowed due to inflammation. They become narrowed due to mucus production. So here's where the real work of respiration is occurring, where the alveoli interface with the capillaries. So we've got pulmonary arteries that have branched into pulmonary arterioles and then eventually pulmonary capillaries, and they're bringing in blood that is very high in carbon dioxide content. That is interfacing at the alveoli in a one-cell thick membrane with the air that's been ventilated in and out. And so carbon dioxide is very high concentration in the inbound blood. It's a very low concentration in the inbound air, and so by diffusion, the CO2 is going to cross over into the alveoli and be exhausted. And then conversely, the oxygen is very rich in that inbound air, but very low in the inbound blood. And so when that exchange occurs, then we now have oxygen-rich blood that can move back out through pulmonary venules and the pulmonary vein back to the heart. Here's an even closer view of the critical interface between the pulmonary capillaries and the alveolus. Here we have red blood cells moving past the alveolar membrane, and this alveolar membrane is typically not very thick, and carbon dioxide and oxygen can move easily and freely across the boundary. The problem is when this alveolar membrane becomes swollen edematous, a CHF situation, or when the inside of that alveolus is full of mucus or blood, the interaction between the capillary and the alveolus is damaged in that case. CO2 can't leave, O2 can't come in, and problems occur very rapidly. So this alveolar membrane concept is something that we wanted to emphasize to you. And the other portion of difficulty breathing patients that don't have ventilation issues, or in addition to a ventilation issue, they have an oxygenation issue. This is a little more complex. This can be caused by several things. First of all, there may not be enough red blood cells going by the capillaries. So if that's the case, then in an anemia, then we're going to have to do something to increase the number of red blood cells going by. It doesn't make any difference how well air is moving in and out and how well gas exchange can occur if there aren't enough red blood cells in the blood that goes by the alveoli. Then there's just not going to be enough oxygen picked up and taken around. By the same token, suppose that there's insufficient blood flow to those pulmonary capillaries for whatever reason, maybe a shock state, or maybe there's a blockage in the inbound vasculature to those capillaries. And so if there's not enough blood going by an alveoli, it doesn't matter how rich the oxygen content is in that air and how well the membrane's working and how well everything else is working. If there's no blood going by, then we're not going to be able to have a legitimate oxygenation. In the rare case where there's insufficient inspired O2, whether it's in a confined space environment or a high altitude environment, of course that also makes sense. If there's plenty of air coming in and out, but that air has insufficient O2, then none of that's going to matter. But really, pretty much those three possibilities, the most common one's going to be where there's an obstruction to the blood flow into the alveoli. But more commonly, we see this bottom case, where the alveoli are damaged from COPD, where the alveolar capillary membrane is not working because there's too much inflammation and there's fluid in there from a congestive heart failure situation, or where the alveoli themselves are obstructed with fluid or with mucus, again, from a CHF scenario or an asthma scenario where there's a significant amount of mucus. Or what about in a pneumonia where that's actually pus, an infected drainage material that's built up in there. So oxygenation issues can be from a number of causes, and you can see that part of figuring out what to do for the patient is to try to figure out what's going wrong with the patient. So when you're talking about bronchioles and what might be obstructing them, sometimes their muscular wall will simply spasm down. Sometimes you will have excess mucus build up in there or be produced in excess in there. I mean, remember that the inside of your entire respiratory tract is lined with snot. It's lined with mucus. That's on purpose. That's to help trap foreign matter that shouldn't be in there. But sometimes the mucus production gets a little bit out of control. Sometimes there's some inflammation that starts to occur in there, which then narrows the lumen of that bronchiole. And remember, these bronchioles are quite small, so a little bit of inflammation goes a long way. A little bit too much mucus goes a long way. And then the other thing is that those muscular walls in the bronchioles can constrict. And so we would need to look at what the actual problem is here in order to figure out the solution. Perhaps we have something for inflammation, steroids. Perhaps we have ways to relax that muscular wall constriction with a beta-2 agonist. We need to figure out what's going on so that we can figure out what the appropriate thing to try would be. So our difficulty breathing patients can have oxygenation problems. They may have ventilation problems. But any way you go, we can assess their pulse oximetry and their capnography, and that gives us a chance to get a glimpse of what's going on. Capnography is going to tell us more about ventilation than any other assessment. Pulse oximetry, especially when it's accurate, and that's a big if, but when you have an accurate reading there, your oxygenation issues can really pop out at you. So what we're going to end up doing here is we're going to look at a number of different differential diagnoses. We're going to talk about CHF, asthma, COPD, pulmonary embolus, pulmonary edema from various causes, and we're trying to look through each of these differentials, determine whether we have an oxygenation problem and using pulse ox to help us, or if we have a ventilation problem using end-tidal as well as the capnography waveform to help us there. Then as we work down those differentials, we're going to do several things. Number one, we need to fix airway and ventilation problems right off the bat. We can't really accomplish anything else until we have enough air coming in and out through proper tidal volume, proper ventilatory rate, and then we have a patent airway. Then we're probably going to need some additional oxygen. In some cases, we may need some non-invasive ventilation, CPAP in most cases. Sometimes some bronchodilators, a beta-2 agonist, may be helpful. We may end up having to mess with preload and increase it or decrease it. Decrease it in the case of CHF would make a huge difference. We may have to do something about perfusion. We may actually need to run fluids and replace volume if perfusion is what's causing some of this. We may need to use vasopressors in that case also. Maybe the cardiac output needs to come up. Perfusion of the lung tissue is a big deal. And if we don't have perfusion, it doesn't really matter how much air we're moving in and out. Sometimes we're going to have inflammation. We're going to need to add some steroids on here. So the overall picture is a number of different differentials, and we're going to divide those into ventilation issues. Capnography will be very helpful. We're going to divide, or they may be oxygenation issues where pulse ox will be very helpful. They may be both. They may be both. And then we have a number of tools in the toolbox. Some O2, some CPAP, some bronchodilators, and then we can adjust some of the components of perfusion. We may even need some steroids at some point. That's how we're going to try to attack these difficulty breathing patients and the numerous different differentials that may pop up for them. So before we dive into case studies and get knee-deep in this difficulty breathing thing, we should probably keep 5 or 6 fairly important things in mind. We need to go ahead and transport our patients. Sometimes transport will solve a lot of these problems. Some of these patients are very complex, and we're not going to get a real definitive answer in the field. Remember, they didn't get bad in 4 or 5 minutes, and we're probably not going to fix them in 4 or 5 minutes. Paramedics were invented to be out there, to look, listen, feel, and think. But they weren't meant to practice medicine. We don't have the depth of knowledge, and we don't have all the diagnostics at hand. We do have a very valuable tool in our cell phone, and we ought to call and talk to doctors about these complicated patients. I really believe the hardest patient for us is probably the COPDer who's got some CHF now. These are very difficult to manage. And so the other thing, the last thing, kind of my little baseline opinion here, is that while we shouldn't practice medicine, we shouldn't also be timid and chicken. And if they do something in the ER in the first 10 minutes that wasn't a repeat of something I'd already done, I think I probably should have done it. So an early consult, don't try to play doctor, talk to a doctor. These are complex patients, and as we move forward with digging through the differentials on difficulty breathing, we want to keep these things in mind.